Good morning, Ashish. Do we hear?
Can you hear me?
Yes, okay, we can now. I'm just going to do a brief setup for you, Ashish. So as I said, before we focus down on these 6 methods, we thought it was important to get more of a state of quality in low and middle income countries and asked Ashish to do a structured review of the literature to talk about what we do know about interventions with different impacts and issues of execution, context, and facilitating factors. Ashish is director for the Harvard Global Health Institute and professor of health policy at the Harvard School of Public Health and a practicing internist. And his major research interests in quality relate to the impact of policy efforts. So over to you, Ashish.
Great. And I apologize for not being able to be there in person. Those of you who know we had a little snowstorm in Boston. I think we got about 28 inches in our town. And so unfortunately, all the flights have been canceled, and I apologize. But I was really looking forward to doing this in person. Can you guys see my slides?
Yes.
Excellent. So we're going to try to see if technology is kind to us today, and this was a little bit of a last minute trying to make this work. But what I'm going to do is talk a little bit about why quality is really important, and everybody in the room knows it because you wouldn't be here otherwise. But then talk a bit about the strategies that the USAID has laid out and kind of what we know about them. And I'm going to not actually spend a lot of time going into that because I'm either happy to do it during questions or I think you'll have a lot of time over the next few days to do it. But I'm going to try to make some broader points about why certain strategies seem to work, why they don't, and what are some broader principles that go beyond any single approach to thinking about quality. And my hope is to speak for about 15 to 20 minutes with the idea that there will be plenty of time left. Okay? So, oops. Now I got to figure out if I can make the slides work. Aha. Okay. So why focus on quality for low and middle income countries? I think we would all argue that this has been an area of inadequate focus. I think there are a variety of reasons. One is that nations are becoming wealthier, and universal coverage has become a big policy goal. And when you put these two things together, you get two things happening. One is a big increase in the demand for healthcare services, right? So we're going to have a lot more people demanding healthcare services. The number of doctor visits, nursing visits, hospital visits, all of that is going to go up dramatically over the next decade. And most of that growth is going to happen in low and middle income countries. But along with the growth in the number of services and type of services, there's going to be a big demand for better services, for better care. And I think we're already seeing that in lots of places. And that is going to happen not just among the wealthy, but among the middle class, and eventually, and really, if you think about it from a moral perspective, everybody ought to be demanding better health services, not just more. So that's one element I think that is going to drive the quality agenda and make quality a much bigger part of what we care about. The other part is going to be the fact that we're going to push on coverage. Policymakers are going to put a lot of scarce resources into coverage, and they're going to demand to see good health outcomes, right? Because the idea is that if we want to do coverage and we want to pay for it, then we want to see that it's actually making a difference in what we care about. And what we care about is not the number of doctor visits or hospital visits. It's actually improving health outcomes. And what's pretty clear, I think, from the data is that coverage alone isn't going to get us there, that it's really going to be coverage plus quality linked together that's going to make the difference. And it's really the combination, and it's not one before the other, it's the two of them working in tandem that's going to lead to better health outcomes. And I'm going to show you some data for over the next minute and a half or two to remind us why that is almost surely the case and why that's how we ought to think about these issues. So why is quality so important? Well, I would argue that we have lots of evidence now that poor quality care can have big effects on health. Here's one study that we did, and I presented some of these data to a subset of you about a year ago, and so I'm going to go through it quickly, but not everybody was there, and a lot of you probably know these data. But we did a study with the WHO where we found, just using a small number of adverse events as our measure, we found that about 43 million people are injured every year in hospitals due to adverse events. It leads to about 23 million disability-adjusted life years lost. About 2/3 of that happens in low and middle income countries. 23 million is a big number, and this was for a small select group of in-hospital adverse events. And when you take a step back and add in all the other ways in which the healthcare system, when it doesn't function well, when it harms patients, put it all into one bucket, what you find is that adverse events, unsafe care, probably one of the top 10 causes of death and disability for the world's population. So this is not a trivial add-on. This is a very big deal, even if you put on your public health hat and think about this from a public health perspective. Even when care is safe, we know it's often ineffective. This is sort of a summary of a lot of work that people like Jishnu Das and others have done, where they've gone out and looked at the quality of healthcare and the effectiveness of healthcare in low and middle income countries. And depending on which study and which measure, if you look at things like if you go to a doctor's office, what is the likelihood that the physician or the provider will ask you the right set of questions and do some very basic physical exam tests that ought to be done for people with your symptoms, it's 30 to 50%. What is the likelihood that they'll get the right diagnosis? Well, the studies vary, but even the best ones suggest in a lot of low and middle income countries, the numbers are sort of 4 to 30%. And one of my favorite statistics is, and not favorite because it was good, but it's just sort of surprising and disappointing, but important, is that the probability of walking out of a doctor's office with treatment that is not going to harm you, right? So getting antibiotics for a viral syndrome is more likely to be harmful than helpful. Getting anticholinergics for childhood diarrhea, probably more likely to be harmful than helpful. What is the likelihood you're going to walk out with non-harmful treatment? 45% from a couple of studies. Some of those numbers are a little higher. Some other studies show the numbers a little lower. But basically, it's a coin flip. And that suggests that we have a lot of progress to be made if we're going to make coverage turn into better health outcomes. The last key point I want to make is around trust. So last month, I was in Geneva for a high-level WHO meeting around the Ebola outbreak and health system responses. And what was really interesting to me in that two-day meeting with the health ministers of the 3 affected countries from West Africa and a lot of other senior leaders from around the world was as we talked about health systems, the one word that came up more often than money, resources, number of doctors, vaccines, drugs, the one word that came up more often than any of those was trust, the lack of trust in health systems. This is a huge issue. You can have the safest, most effective healthcare system in the world. If people don't trust it, if patients feel like they are not treated with dignity and respect when they interact with it, it is fundamentally not going to work. It's not going to get you where you want to be. And that, I think, is a huge issue. All right, here we go. So what strategies are there if we want to make the healthcare delivery system work better? There is a whole long list. I'm going to talk about the 6 that were outlined in the task for this committee. Clinical in-service training, and again, I'm not going to go through each of these in great detail because there's a lot more expertise in the room than I have on them, but this is really about training providers directly in an area of and getting to improving their knowledge and expertise. Supervision, a notion that in a lot of contexts you have a more professional or higher level provider who might be overseeing a whole group of mid and lower level healthcare providers. Can you intervene on that? Can you use that as a mechanism for quality assurance? And there is some good data to suggest that you can. Standards-based management and recognition is a lot like what it sounds like. It's about finding external standards, evidence-based guidelines, and really pushing provider organizations to be more consistent with meeting those guidelines. Client-oriented provider efficient is a little bit of a funny term, COPE, but what I like about it is very focused on getting providers to participate in the process of both discovering the problems, discovering the solutions, and working towards improving delivery. Collaboratives, again, these take on many forms. They often have multiple providers engaged. There's a whole series of things that go into effective collaboratives, from identifying priorities, having data systems, getting buy-in from clinical leaders, and there's plenty of evidence that in certain contexts, collaboratives can work. Accreditation often focuses on structural and processes issues and really focuses on ensuring that healthcare organizations have the capability and the process in place to deliver high-quality care. And, of course, there are others. What Sheila and Jillian asked us to do coming into this meeting was to begin with a little bit of a systematic review light. And I emphasize light because I would not argue that we have comprehensively looked at all the literature on these 6 strategies. But we did look pretty hard at a lot of the different ones. And here's what we found. We found that each of these strategies has evidence behind it. Each of these strategies can work and has been shown to work in different contexts. But each of these strategies has plenty of literature and plenty of data to show that it often doesn't work. Right? So none of them is a slam dunk where we can say, boy, there's just one strategy that seems to work consistently in every context, that none that we could identify really fit that criteria. The other big point is that each of these strategies has the ability to change what providers do, but they're far less often able to change how patients do. Right? So their impact on patient outcomes is far more muted than their impact on changing provider behavior. And while we care about changing provider behavior, I would argue what we care most about is improving patient outcomes. And that's been much tougher to show with each of these strategies. They vary in their approach, right? Each of them is a little different. But what I would argue is that they actually have a lot more in common than the differences among them. So we can talk about the differences among the different strategies. To me, they actually have a lot more in common than they do the differences that explain why they are different strategies. So why do some strategies seem to work and others not so much? And I want to lay out a few principles pretty quickly, and then I'm going to go through them in a little bit more detail. So when I look at common features of successful strategies, and a lot of people have written about these things, but this is my effort to synthesize how I've thought about this. They tend to engage frontline clinicians. So one of the key things is getting buy-in from the doctors and nurses and other providers who are going to be doing it. They almost always involve measurement. It really is hard to improve if you're not measuring along the way. And I'll talk more about the details of each of these. They involve local customization of interventions. Even the most basic things that you think you could just pick up in one place and put into another, what we find is that customization is really important. They involve setting targets and having feedback loops, because I think that's the only way we all ever learn. And they involve buy-in from leadership. I brought that up from collaboratives, but there are other contexts in which the organization has to be bought in. And the last point is that each of these requires paying attention to culture and context. And so when I think more broadly about why do some strategies work, my general inclination is to say it's not really about what you do, it's about how you do it. And let's get into that at one level deeper than I have so far. So what do we mean by how you do it? So is the target of improvement meaningful? I think this is one of the key questions. Is it meaningful to patients? Is it meaningful to clinicians? By the way, if it's going to be meaningful to patients, then it is often also meaningful to clinicians and vice versa. Those two things are not totally different. They're not always the same, but I think thinking about, is this something that people ought to care about, that people actually care about? A vast majority of quality improvement strategies, when implemented, I find fail this test, which is this something you really care about improving? Is it meaningful in a deep way? Measures. Now, what we all would love to do is measure the outcome of interest. But it's hard often to measure that, and so we go for surrogates. And one of the things that makes a strategy more successful or less successful is to what extent does the measure capture what matters? Or is it at least close? I'm not somebody who believes you got to measure exactly what you want to improve perfectly, but you got to get close. And the further you are, the more of a surrogate measure it is, the less likely you are to both engage clinicians and less likely you are to make a difference. Are there targets? I suggested that targets are really important, and I would argue that they should be inspirational. When I've seen really amazing quality improvement things take hold on a large scale, it's rarely about saying, you know, we do this at 60%, let's get to 70% as our goal. The inspirational, aspirational goal is, let's get to 0 infections in our hospital in the next 3 years. You may not achieve it, but that's the goal that motivates people and makes people work hard. And then if you're going to set those goals, you need to be able to pay real-time attention to progress. This hampers a ton of quality improvement efforts where the data lag, the time lag for getting data is so bad that you're making changes and you have no idea whether it's making. And a couple of last points. Is the intervention customized for local culture? I look at even something like the checklist that Peter Pronovost created for reducing central line infections. It's very simple. You'd think you could just take that checklist and implement it everywhere. And Peter would argue that even that requires a certain amount of local customization because people are different and contexts are different. And that's true as much for educational interventions as it is for organizational interventions. And then is it sustainable? Because, of course, the point isn't can you show that it worked in 3 months and walk away with a nicely written paper that gets into a journal. The goal is to make a difference over the long run. And so thinking about will the effects persist over time is a big issue because a lot of interventions, especially a lot of educational interventions, tend to work for a very short period of time, and as soon as you take the education away, it tends to dissipate. And as the organization bought in, one of the things that we see over and over again is you can intervene, but unless the organization has made a commitment in the long run to sustaining it, to working on it, it won't. And the cognitive dissonance issue is really important. Thinking about this, one of the things that we find, and when I've looked at studies and interventions, is, for instance, we will ask providers to, hey, cut waste. We're going to ask you to reduce the number of tests, reduce the number of, and yet the organization is still getting paid based on the number of tests they order. You can get people to change their behavior, but if that creates cognitive dissonance where the organization feels like it's going against their interest, it's very hard to both be effective and to sustain it over time. And that, I think, is a really important issue. So I'm going to pick on 3 specific examples, mostly from the U.S., but I think they highlight, not U.S., high-income countries, but they highlight issues that exist everywhere. And these are 3 that I'm actually pretty big fan of. And so I actually picked on them because I think I like them as quality improvement efforts, and yet they have not always worked, and I thought it'd be worth kind of thinking about why. So one is performance-based incentives. It's something that's used in low and middle-income countries as well. We often refer to it here as pay for performance. Pay for performance, I'm a huge fan. I've written broadly about why I think it's a great thing, and yet the data suggests it's been pretty disappointing. And what we find is that a lot of the performance programs have targets that are not meaningful to clinicians, and so you're asking them to change their behavior on things that they don't fundamentally care about. And the incentives are structured not very well, right? They're either too small or they're really structured in ways that are confusing, and they don't engage people. Information technology adoption is another one where I've written a lot and thought a lot about, where we think it can have a big impact on quality, but it has been pretty disappointing. And that's because we often forget that the intervention is not about technology adoption. It's really about workflow and organizational change and organizational focus on quality. And it's about the contextual factors. And what I mean by this is what we see is that when organizations are very successful at implementing information technology, they've thought through all the contextual factors like who's using it, how is data being shared, a whole set of things that people don't pay close attention. And even things like checklists, I already made this point, have been not as much of a slam dunk as we had hoped. And I think it's often because we pay inadequate attention to customization and the local culture in which it is being implemented. So finishing up with a couple of slides, I think thinking ahead and thinking about the importance of quality, it has struck me as I have thought about this and listened to folks on this committee and others, that quality is central to getting our healthcare investment right? The world puts a lot of money into healthcare, about different estimates, but probably something in the order of $7 trillion goes into healthcare services. Focusing on quality, and that number is going to go up a lot. Focusing on quality, I think, is central to making sure that investment really pays off. Improving quality is of paramount concern. I think it's as critical as focusing on coverage. I think we'd all agree that it has not gotten as much attention, but it's, I think, just as important. And our focus when we've thought about quality has been about finding the right QI approach. And I think, to me, the data says there's no such thing. There is no one right approach. There is no one way to do it that works consistently. And I think if we're going to be effective at improving quality and improving the way we deliver healthcare, we have to appeal to the innate desire to get better. All of us have that. All of us want to get better over time, and I think we have to have strategies that appeal to that. but also make the status quo uncomfortable. I think the status quo on the state of healthcare quality in the world ought to make all of us uncomfortable. It is really unacceptable. We shouldn't spend $7 trillion and get what we get for healthcare. And so making people uncomfortable, but also appealing to a sense of innate desire to get better. I don't want to underestimate the importance of incentives and policies. I think you can have quality improvement strategies within organizations, but if the broad incentive program, the broad policy context doesn't allow that to flourish, the best quality improvement strategy in the world isn't going to sustain itself and is not going to have an impact. And I think ultimately focusing on results that matter and not over-prescribing the approach. I think about, for instance, the examples in the VA, which made big improvements in quality in the 90s. Again, what they did was they focused on bottom line things that matter to patients, but didn't tell people how to get better. And people are very creative and give them the right incentives, give them a set of tools. They figure out how to get better in a way that works for them. And so being less prescriptive about how you do things, but being more prescriptive about making sure people are held accountable is, I think, the strategy that works. And then creating momentum for improvement. This is really this notion of appealing to people's innate sense of wanting to get better and saying, look, wherever you are, let's get moving on getting better, and let's not get caught up in what the perfect approach to doing is. Because I think when it comes to quality improvement, we can all expect better. We can expect better from our healthcare, but we can also expect to do quality improvement better. That's it on my end. Thank you all for listening, and I'm happy to take questions, comments, whatever would be useful.
Thank you, Ashish.